Very good morning to you all, and welcome to second part of our two-part webinar series organized by the Department of Orthopaedic Surgery on New Frontier in Sports Medicine. We'd like to thank those who have joined us last week, and we hope that you have learned a thing or two from the first session. This week, we'll be looking into other subspecialties such as hip, foot and ankle, sports exercise, and sports physiotherapy. If you have any burning questions, do submit them by clicking the Zoom Q&A button on your screen. So, without further ado, let's welcome Dr. Paul Senu, who is the Director of Sports Service and a Senior Consultant at SGH Orthopaedic Department, where he will share more insights on sports services at SGH. Dr. Paul, over to you, please. Prof, you are muted. Okay.
Yeah. Okay, can you see my screen now?
Yes, we can.
Yeah, okay, that's great. All right, good morning, everyone. I'm Senu. I'm the Director of Sports Service in the Department of Orthopaedic Surgery in SGH, and it's wonderful to see so many interested participants with us today. Today is a continuation of the session that we had last week. We're looking more at hip, knee, sports medicine exercise, as well as rehabilitation. All right, so before we start, I would just like to share some information about our orthopedic sports service. So the SGH Sports Medicine Service is the largest orthopedic sports service in Singapore. We partner very closely with the SingHealth Duke NUS Sports and Exercise Medicine Center. We comprise of 10 orthopedic consultants, and we have 2 visiting sports and exercise medicine physicians. In so doing, we can provide a full suite of sports medicine as well as surgery expertise. So we are establishing now a Singapore Sports and Exercise Medicine Center at SGH. This is going to serve as a one-stop sports medicine center, and this was done largely in response to the increasing demand for sports medicine care. Because sports medicine benefits not just elite athletes, but we are also targeting sedentary individuals who are looking to start an active and healthy lifestyle. And sports medicine actually benefits from the very young to the very old, and also those who are looking to do exercise as an effective intervention to manage their chronic disease. What we have here in SGH is a one-stop center where we work together in a multidisciplinary approach between sports orthopedic surgeons, sports medicine physicians, sports physiotherapists, specialty nurses, podiatrists, dietitians, as well as psychologists. So we provide a wide spectrum of clinical services and hence holistic management of sports injuries. And this has been shown to provide better outcomes. And this is the way that sports medicine has been organized around the world. What we can do is we have a dedicated sports medicine sports clinics, which are operated on a team-based approach. This is a one-stop center where the patient is first seen by a sports physician or a sports surgeon. The diagnosis is made and all the necessary investigations such as x-rays or MRIs can be performed within the clinic complex itself. And then we do sports rehabilitation. So if needed, there is a direct and immediate referral to an in-house sports physiotherapist which can be made. This can be in the form of prehabilitation before your surgery, post-operative rehabilitation, general muscle conditioning, or return to sports programs. We can do clinic-based interventions such as ultrasound-guided injections or shockwave therapy within the complex itself. In addition, most of our sports surgeries are performed through minimally invasive techniques such as arthroscopy, and these procedures can be performed as day surgery. But we also have a full suite of 10 specialists and a comprehensive suite of sports surgery on all major anatomic joints. The combined experience of our specialists actually allow us to perform complex and revision surgery in sports medicine as well. And hence, we are also a tertiary referral center for sports medicine. We are also in the process of forming a joint preservation center, and this has a special interest in interventions to prolong the health of natural joints and to reduce the need for joint replacement surgery. This preservation of native joints enables the individual to participate in a higher level of activity and allows and avoid the problems of joint replacements such as infections, loosening, and any need for revision surgery in the future. In addition, we provide exercise prescription for those who are seeking to start exercise of some sort. And we also do pre-participation screenings before they actually go into active exercises or more vigorous sports. And constantly, we're doing clinical audits and quality improvement projects to ensure we provide the best possible care to you. Our Sports Medicine Center is housed in the new Orthopaedic Sports and Joint Center in the Outram Community Hospital, which many of you would have seen. This is just a stone's throw away from the Outram Park MRT station. And being in the fully furnished new building, we have new consult rooms. You can see the SGH Rehabilitation Center housed within the same level as our Orthopaedic Sports and Joint Center, and is fully equipped with a gym as well as a running track. And we have also treatment as well as procedure rooms for us to do day interventions. So we look forward to letting us work with you to get you back to your active lifestyle. All right, without further ado, I'm going to go on to my talk, which is on hip preservation, a new treatment paradigm. So hip conditions largely manifest early as young hip disorders that, if left unchecked, can progress to full-blown osteoarthritis of the hip. We know that hip replacement is an excellent treatment for osteoarthritis of the hip, but it is not suitable for young or active patients. The reason is because in this group of patients, they have earlier wear and eventually may require multiple revision surgery in the future. And in addition, they have complications of hip replacement such as infection, dislocation, or loosening. So for example, you see this patient here. This patient has hip dysplasia, and actually the joint looks quite good when he first came to me. In 5 years' time, we can actually see the progression of the hip osteoarthritis because the space that we typically could have seen has narrowed, and now it's a bone-on-bone contact. And eventually, the patient went on to have a hip replacement. So the whole idea of doing hip joint preservation is to prevent these progression to osteoarthritis and the need for hip replacement in the first place. So hip preservation has now become a subspecialty area within orthopedic surgery, and the focus is on treatments to preserve the native hip joint. And the benefits are patients can resume a normal life with a high activity levels, and it can even participate in competitive sports. It helps to improve and eliminate pain, and can potentially prevent or delay the development of end-stage hip arthritis, and therefore avoid hip replacement surgery. This is a rapidly progressive field within the last decade, and hence we call it a new paradigm. And in fact, we have established a SingHealth Hip Preservation Service with a specific intention to streamline and optimize management of young hip disorders across all the SingHealth hospitals. So just as a recap, looking at this, to remember the anatomy of the hip consists of the pelvis, and at the end of it, you have the acetabulum, which forms the socket of the joint. And then we have the thigh bone, which is the femur, and at the end of it is the femoral head, which is the ball. So the hip joint is essentially a ball and socket joint, and in between these surfaces are the cartilage, and this is necessary to allow smooth movement within the hip joint itself. And around the cartilage, around the acetabulum itself, you have a fibrocartilaginous structure called the labrum that surrounds it, and we'll go a little bit more into it later. So as an overview, during my talk, I will talk about three main conditions, which are labral tears, femoral acetabular impingement, and hip dysplasia. Of course, this does not cover the full spectrum of hip preservation hip disorders, but due to the limited time, we will present these three most common conditions, which is relevant to most of us. So as we have discussed earlier about the acetabular labrum, this is a fibrocartilaginous circumferential structure that surrounds the entire acetabulum or the socket. It creates a fluid seal within the joint, and you can see this in arthroscopy. During arthroscopy or invasive surgery, we actually distract the joint. And as we reduce the joint, you can see a closed watertight seal, and that forms that fluid seal throughout the entire ball and socket joint. So this fluid seal allows uniform distribution of compressive forces on the cartilage. It helps to maintain joint stability. It provides lubrication by keeping the joint fluid within the joint, and therefore provide a smooth gliding surfaces between the cartilage surfaces. And it also provides nutrition to the joint cartilage. So labral tears happen when there is a tear within the labrum from its bony attachment. And when that happens, this is painful because as the ball and socket joint moves against the labral tear, there's a lot of inflammation and pain. So labral tears are common. If we look at examination of cadaveric specimens, right, with an average of about 80 years, more than 90% of these specimens will have labral tears. And most of these tears are atraumatic. That means you will not remember any history of any fall or injury. But out of those that are atraumatic, more than 90% of them have some kind of bony abnormality within the hip itself. And this is usually in the form of a femoral acetabular impingement or hip dysplasia. The traumatic causes of labral injury make up less than 50% of cases. Usually, patients remember twisting the hip, example, following sports or after a fall. Or there could be a hip fracture dislocation, or there could be causes loss of the labral fluid seal, and in turn, this leads to cartilage damage and osteoarthritis. So the most common presentation of a labral tear is pain, and usually the pain is in the front of the groin or the side of the hip, and it's less common so in the buttock. And this pain can be very severe, especially in the acute phase, and patients even complain of night pain and pain with movement. And it's usually activity related. Walking, pivoting activities, impacts activities such as jumping or running all cause pain. They may have difficulty putting up their shoes and socks. They may have difficulty climbing stairs. And sometimes you can hear snapping, popping, or locking as the labral tear gets caught within the joint during its movement. Usually we do an MRI for diagnosis, in which you can see here, this is the bony rim, and this is the labrum, and you can see a fluid signal, which is this white signal going into the labrum, and these are all signs of a tear. So the treatment for labral tear include conservative or non-surgical treatment, labral debridement, a labral repair, or a labral transplant, and we can go into these individually. For non-surgical interventions, the most common is activity modification. You should rest during an acute period of pain until the pain settles. And at the same time, you want to avoid hip bending and turning activities that will cause the labrum irritation. We give anti-inflammatory medication to reduce the inflammation. At the same time, once the pain starts to settle, we start on a course of physiotherapy. And this physiotherapy should be continued for 6 weeks to 3 months, where we do stretching, daily stretching exercises, and then after that, strengthening exercises. So here in the picture, you can see strengthening of the outer thigh muscles. This can be starting off with just a free lifting, and then after that with weights and extension exercises where strengthening the buttock muscles. Sometimes we give injections. Because the hip is a deep joint, we cannot just give the injections blind. So usually they need to be guided either by x-rays or ultrasound. And the injections can be in the form of steroids. We use steroids sometimes as a diagnostic test to ensure that the pain actually comes from the hip joint, and also as a form of pain relief. We also do injections of hyaluronic acid or biologics such as a platelet-rich plasma, but I need to caution you that at this point, we have limited evidence for the use of injections purely for labral tears, although they have been shown to have some benefit in the setting of osteoarthritis. But more information needs to be obtained before we can recommend this as routine treatment. So next we look at labral debridement. What labral debridement means is to essentially clear up the area of the subsurface tears. So this is only applicable if the tear is on the surface and not down to the cartilage and labrum junction. We can do that in irreparable labrums, for example, in elderly patients to buy time before a hip replacement. And it does help to reduce pain and mechanical symptoms. However, we know that it does not restore the fluid seal, and it has no bearing on the progression to full-blown osteoarthritis of the hip. Labral repair is our preferred method. In this case, you can see a tear in the labrum. What we then do is we fire suture anchors, which may be plastic screws or a ball of suture, right into the bone, because we want to attach the labrum to the bone. And we pass an instrument, use an instrument to pass the sutures across the area of the labral tear. And following that, we retrieve that loop of suture. And then we tie down the area of the labral tear. So animal studies have shown that a repaired labral tear has the potential to heal by scarring. And current research suggests that whenever possible, we should try to repair the labrum. The reason being that we get superior clinical results. This is in terms of better patient-reported outcome scores. And there are some papers that even suggest that it does slow down the radiographic progression of osteoarthritis. The next option is a labral transplant. This is largely a salvage procedure for irreparable labrum. That means there's no way you can repair the labrum, and yet you want to maintain the integrity of the labrum and the fluid seal, and then we will do a labral transplant. This is usually following a previous labral surgery where the labral condition is very poor, or the labrum after multiple chronic tears have turned into bone, a process we call labral ossification, or when the labrum is very degenerate. And how we do the transplant is by using either from the self, what we call autograft, which is from the thigh, the iliotibial band, or from the hamstring tendons. Or sometimes we use allograft, the soft tissue from other people. So what you can then see here is us trying to put in the graft, and that's what the graft looks like. Here you can see an arthroscopic photo where there's a defect in the labrum. This is a normal labrum here, and in between there's a defect, and then we fill this defect with a new graft. and so recreating the whole labrum. Now I'm going to talk a little bit more on the next condition, which is femoral acetabular impingement. Femoral acetabular impingement is a disease process where there's mechanical abutment between the proximal femur, which is the ball, and the acetabular rim, which is the socket, during the terminal range of hip movement. And this in turn results in cartilage and labral damage. This is largely postulated to be a main cause of what we used to call idiopathic hip osteoarthritis. Idiopathic means we don't know what the cause is. And so actually many authors have came out to say that probably femoral acetabular impingement is the main cause of these hip osteoarthritis. So if you look at the animations below, there are two kinds of femoral acetabular impingement. One is in the cam, where the problem is in the ball part, that means the proximal femur, and the pincer type, where the problem is in the socket. So let's look at this. So in a cam, the proximal part of the ball is very prominent. So when the hip goes into bending and rotation, what then happens is that there's impact along the junction of the cartilage and the labrum. You can see this red area where the pressure is very high. And then what happens is the cartilage will strip off. When the cartilage strips off, eventually this becomes an unstoppable process because it starts to strip all the way down, and then you get a full-blown osteoarthritis of the hip. In the pincer, what happens is the acetabular rim is very prominent. So what happens now is the labrum is caught between two hard surfaces. So when the hip then goes into bending and rotation, the labrum gets crushed, and then what you see is tearing of the labrum. In time with multiple tearing, this area of the labrum turns to bone, a process we call labral ossification, and causes the head to lever backwards and cause a cartilage damage in the opposite area. And again, this damage to the labrum as well as the cartilage will in turn lead to the osteoarthritis of the hip. So how do the patients present? They all have pain in the front and side of the hip, similar to what you see in labral tears. And this occurs with activities that require high bending as well as turning of the hip. And this typically occurs, as simple as, prolonged sitting or driving, because the hip now needs to be brought up to a bent position for a long time. This can happen with stairs, with squatting, and in activities or sports that require a lot of bending and turning, such as hockey, soccer, gymnastics, martial arts, for example. And sometimes patients present with painful clicks and locking, and this is suggestive of a labral tear. Usually, when you come to the clinic, we will do an examination. Some of the patients walk with their leg turned outwards in order to avoid this impingement position. They may have a C sign like what you see here. Essentially, the patients tell you the pain is in the front and the side of the hip by cupping their hand around the hip. And when we check the range of motion, typically they have restricted range of motion, especially on bending forwards and turning inwards. So we do some provocative tests, as what you see in this picture here. When we bend the hip up and start to turn it inwards, the patient reproduces the pain that he experiences. So we go on to do some X-ray. Here you can see the labral calcification and ossification occurring following a labral tear. You can see that the femoral head, which is the socket part of it, is no longer as round as it should be, and you can even see a bump here. If you draw a circle, you can see this whole area represents where that bump is, and that's what we call a cam lesion. And throughout constant knocking, you can even form a cyst, as what you see here. And this is an area of weakness, and it's very painful because now there's a cyst within the bone. So we want to do some advanced imaging, such as a CT scan. So here you have a 3D reconstruction of the CT scan, where you can see that bump here in the front. And then if we look more to the side, you can see that very obvious bump in the front as well as side of the hip. So when he bends, this is going to impact this area of the bone. And that's going to cause pain and labral cartilage damage. On the MRIs, we can see a tear in the labrum. This is this fluid signal here. And similarly, on the MRI, you can see that loss of curvature on the ball part of the hip joint. So again, we can try non-surgical treatment. So this usually involves activity modification where they rest during an acute period of pain. We avoid hip bending as well as turning activities that lead to the pain. We give anti-inflammatory medication. We do the physiotherapy with strengthening and steroids, stretching and strengthening. And as a last resort, we can consider steroid injection just for temporary pain relief or as a diagnostic test. But we must bear in mind that non-surgical treatment does not actually get rid of that bony deformity. So the process still continues, and usually the pain does come back. In such cases, we need to consider surgery. And the whole aim of the surgery is to improve this movement clearance of the ball and socket joint. And what we do is to reshape the entire acetabular rim or the proximal femur, which is the ball part of the hip joint. And at the same time, we treat the labrum and cartilage problems or disease. And then this provides symptom relief in terms of improved pain scores, hip outcome scores, as well as pain satisfaction and range of motion. And potentially, it may even delay the onset of or progression of the osteoarthritis of the hip. In the past, this used to have been done through a large incision. This is a 20 centimeter incision through a surgical hip dislocation where we cut, and then after that we have to sort of do a small saw cut to the proximal femur, and then bring out the hip through a dislocation. And then after that we will burr down this deformity, and then after that repair that labrum. But nowadays, the trend is to go towards increasing keyhole FAI resection. And this can be done through small portals, typically anywhere from 2 to 4 portals. The more portals are required if you're doing more complicated procedures, such as a labral transplant, for example. Yeah. So here you can see that large bump we see during the surgery. That bump can be seen, and after we clear it off, now there's clearance between this is the ball and the socket, and the labrum is here. And similarly, what we can see is when we go into the hip joint, we can see this tearing of the cartilage and labrum junction. When we expose that bony deformity, what we call the pincer, where the rim is has abnormal bone around the rim, we burr it down, and then after that, we reduce the hip, and the hip moves within the confines of the labrum. So here you can see a case, the very obvious bump here. You really want to get it down to a nice reshaping. And that's after surgery, where we get that nice concavity. So we look at the evidence for arthroscopic FAI surgery. So nowadays there's been there has actually been multiple studies throughout the years, but in recent years at least, we now have multi-center randomized control trial, and this to the doctor is the highest level of evidence. So in 2018 in the UK, they published a study where, involving 23 hospitals and 348 patients, where they compared arthroscopy versus a personalized physiotherapy-led care, which means the physiotherapy decides, what is best for the patient. So there's some variability, but ultimately it's an experienced physiotherapist who decides what the treatment is. So within 12 months, we can see that the arthroscopy group had improved outcome scores measured through the IHOT 33. And then in the FAI trial, also done in the UK, where they had 222 patients, and symptomatic FAI confirmed with imaging. Again, we compare arthroscopic surgery versus physiotherapy and activity modification. Within 8 months, the arthroscopic group showed improved outcome scores, as well as bending range of motion. And then in the first trial, which was just published only, it's a global multi-center trial involving Canada, Finland, and Denmark, with 214 patients. So they were looking at 2 groups of treatment arms. Both groups had surgery. One was just a washout, essentially, with or without labral repair and debridement, depending on whether the labrum was unstable. And the second did an arthroscopic bony reshaping, or what we call FAI surgery. And it shows that there's a higher reoperation rate if you just wash out compared to if you do the bony resection. And that rate is about 2.7 times, which means that it is probably, we need to address the cause of the problem, which is the bony deformities. Just going in to repair the labrum and washing out the hip joint is not going to solve that problem, because the pain will recur and an FAI resection is required. So now we move on to the third condition, which is hip dysplasia. Hip dysplasia is very common in Asians, and what we see is a deficient coverage of the socket over the ball. And essentially, what you want is this socket to cover the ball so that there's uniform force distribution when you're loading the hip joint. So in hip dysplasia, what you have is a deficiency in this coverage. And when there's a deficiency in this coverage, when there's loading of the hip joint, what then happens is get eccentric loading. All the load goes to the side of the cartilage as well as the labrum. What then happens is the labrum tears, the cartilage starts to wear out, and the hip starts to move, a process we call subluxation, and can even dislocate. All right, so what then happens is once you have any of these conditions, the next progression would then be hip osteoarthritis. And it is a leading cause of hip osteoarthritis, accounting for about 20 to 40% of cases, depending on where you're looking at. So 25 to 50% of hip dysplasia cases actually show radiographically evident, that means X-ray evident osteoarthritis at a mean age of around 50 years. And if there's any evidence of subluxation where the hip is starting to move upwards, all these patients will show evidence of osteoarthritis by the age of 50. And we use the lateral center edge angle as a measure, which I'll show you later. This means is that with more severe dysplasia, it's very likely that these patients will develop osteoarthritis. And if we look at lateral center edge angles of less than 20 degrees, all these patients eventually develop osteoarthritis at a mean age of 65 years old. So how does it present? It's usually, again, pain at the front and side of the hip. And a lot of patients come in with a painful limb, where you can see as they walk, they start to have pain and they start to sway their body to the side and walk with a limp. So on the X-rays, what we can see is there's insufficient coverage of the socket over the ball. And in severe cases, so what we measure now is a lateral center edge angle. Essentially, what we're looking at is how much coverage of the femoral head the socket provides. And usually we like these angles to be more than 25. So these are all dysplastic. And then we look at how much sloping there is of the weight-bearing area of the socket. And we like it to be flat, because the more flat it is, the more even coverage there is. So we like all these numbers to be less than 10 degrees. And here you can see, because of the eccentric rolling, you have a fracture actually on the outside of the socket joint, the socket part of the joint. And we also measure the front part in terms of the coverage. And again, we like the figures to be more than 25 degrees. So on the MRI, you can see that same patient with the rim fracture. This is the bony part of it. There's fracture already. And then you can see a tear in the labrum. And likewise, you see all these bone cysts throughout. All these bone cysts are a sign that already the cartilage underlying is worn out. And this is already progressing towards osteoarthritis of the hip. So what will happen then if we do nothing for such cases? So these are two real-life examples of young patients who have hip dysplasia. Here you can see inadequate coverage, acetabular rim fracture. Within 5 years, this patient has progression, because you can start to see the hip is starting to move up, and there's loss of the joint space. All right, and this is by this time this is already full-blown osteoarthritis. In this other patient, you can see both sides of the coverage is inadequate. Already they are starting to sublux outwards. So when she presented to me, on the left side, already you can see subluxation. And within 2 years, you can see the hip is starting to dislocate. Once you reach this stage, there's nothing more we can do except to offer a hip replacement. But these patients were all in their 20s, so they were not suitable candidates for hip replacement. Or at least, if we do a hip replacement, we are looking at a lifetime of revision surgery. So it's important for us to intervene young. So once again, we review the treatment options for hip dysplasia. One is, again, non-surgical. We essentially wait for hip replacement. And I think these are suitable for slightly more elderly patients past the age of 55. Essentially, we recommend they limit their activities. You just take pain medicine whenever the pain comes. We do some physiotherapy to help with the muscle strengthening, to do some dynamic stabilization of the hip. But usually the result is unsatisfactory because the pain remains and they're very limited in terms of the activities they can do. If so, then we do surgery. And this can be in the form of a bony reorientation, what we call osteotomy. And because the problem is in the pelvis, we need to reorientate the pelvis, a process we call periacetabular osteotomy. That means we cut around the socket, which is the acetabulum, and then we move the socket to provide the coverage. In some cases, we can do keyhole surgery, but I need to caution you that this should be judicious use only in early cases of borderline hip dysplasia, where osteoarthritis has not yet set in. So again, we revisit that case where there's acetabular rim fracture. Post-surgery, we shifted the pelvis to provide coverage all the way from here to here. We fixed that rim fracture fragment. This is the cut that needs to happen. Essentially, this patient had long-standing right hip pain with acute exacerbation over 1 year. And after surgery, within 6 weeks, she was able to ambulate without crutches. At about 8 weeks, she was able to ambulate without Trendelenburg, which is a limp. And 3 months, she was back to work. And this is her walking at 3 months in my clinic and able to squat as well. Something which we cannot really promise a hip replacement patient can do. Right. Next, we look at opposite side is still within the hip joint, but on the left side, the hip is starting to move outwards. Again, we corrected that with a periacetabulum osteotomy. We brought the hip back down, and we corrected the lateral center edge from -5 degrees to 30 degrees, which is normal. We want anything in excess of 25 degrees, and we made it a much more horizontal hip coverage. This is what you can see. We make the bone cuts around the socket or the acetabulum and put a bone graft in to fill the gap. And this is at 1 year when the hip has completely healed, or rather the pelvis has completely healed up. And this patient is active and able to start walking independently at 3 months, has started to run around 5 kilometers at 6 months, and was running about 8 kilometers at 8 months. Okay, this is another case, 40-year-old lady, both sides hip pain for about 10 years. By the time he saw me, was walking less than 400 meters, limited largely by pain. We did the left side and then the right side. So again, you can recall very little coverage. And then after that, post-surgery, we improved the coverage. We made the acetabulum much more horizontal. Within 3 months, was able to walk independently. And in 9 months, was pain-free and able to run about 5 kilometers. Yep, and so you can see that running and very smooth squatting movement. So it doesn't mean after surgery, most patients eventually can return to a very reasonable lifestyle with active sports. So looking at the results of periacetabular osteotomy, this is data coming from Switzerland, the burn hip unit where they have the highest experience in terms of PAO. They look at all their patients which have followed up over 30 years. So at 10 years, the survivorship means 88% of these patients did not require a hip replacement. You have to bear in mind, if there's subluxation, probably within 5 years, most of these patients will end up with surgery or hip replacement. So in 20 years, this drops, but still about 60% are able to avoid a hip replacement. Of course, as you go on to 30 years, then this drops. But at 30 years, this is already very long down the way. If we had done a hip replacement right at the start, within 10 years, we are looking at a similar rate of revision. So actually, if we compare periacetabular osteotomy to total hip replacement in a young patient, certainly is something, the results are definitely comparable, if not better. And don't forget, you actually get to preserve your native hip joint and potentially enjoy a higher level of activity. So is there any role for hip arthroscopy or keyhole surgery? At this point, the indications are still unclear. So we tend to do these in patients who are more within a slightly gray zone of about 45 to 55 years. And when the hip dysplasia is very borderline, those angles are between 20 to 25 degrees. And there have been some studies that show improvement in outcome scores. Here is a hip arthroscopy in a patient with dysplasia. You can see a large labral tear that extends from the front all the way to the side. And centrally, there is a ligamentous rupture. Here, this is a cartilage deficiency already. We're stimulating the cartilage. You can see the bleeding that suggests that, potentially there's a potential to grow fibrous cartilage. And then we had repaired the labrum from the front all the way to the end. And then at the end of it, when we come up, we have to close the hip capsule very tightly to ensure that there's no dynamic instability arising from the soft tissue defect. So it can be done, but it must be done early. Before osteoarthritis actually sets in, and in a select group of early borderline hip dysplasia cases. Right, so the take-home message is that young hip pre-arthritic conditions do need early assessment and treatment. We want to intervene before arthritis has set in, because by that time it's too late. And preservation of the native hip joint definitely allows a more normal and active lifestyle while avoiding the complications associated with a hip replacement. Right, thank you. With that, I'll end my talk. Right now, I would like to invite my good friend, Dr. Nicholas Yeo. He's a consultant orthopedic surgeon with the department. He's also the director of the Foot and Ankle Service at SGH and a clinical assistant professor with the NUS Medical School. He has gone overseas to do a year-long fellowship in Canada and has also done separate shorter fellowships in Germany. His subspecialty interests are in foot and ankle surgery and lower limb reconstructive surgery, and he's an advocate of minimally invasive or keyhole foot and ankle surgery. So without further ado, I'm going to invite Nicholas to share his thoughts with us. Nick, do you want to share your slides? Oh, good.
Okay, thank you for the introduction, Sing Yu, and for a very enlightening talk on hip conditions. Hi, good morning, everyone. Welcome to this morning's public forum. I'm Nicholas, and I'll be talking a bit on sports-related injuries of the ankle. Okay, so ankle sprains or ankle injuries are exceedingly common. They account for about 10% of emergency visits in our hospital and up to about 30% of sports-related injuries. As a foot and ankle specialist, I often see these patients. In fact, about a quarter of the patients that walk through my clinic doors have some form of ankle injury. Singaporeans have increasingly been embracing a more active lifestyle. Certainly in pre-pandemic days, these are all the rage: ultramarathons, Spartan races, triathlons. Nowadays, organizers have pivoted towards virtual runs, still very popular, and not to forget our weekend warriors. So it's not surprising that we're seeing a lot more patients who come in with ankle sprains and ankle injuries. So the good news is that about 70–80% of patients who have a significant ankle sprain or injury do pretty well. Most times, if it's a first-time injury, after a little bit of rehab, most patients are able to return to sport. However, studies show that at least about 20% of patients end up re-injuring the ankle at some point in their lives. So it's not entirely a benign injury after all. About 1 in 5 develop chronic instability of the ankle. So what is chronic instability? So a patient might come in and tell me, hey, doc, my ankles kind of feels a bit weak. It doesn't feel very stable. It gives way when I try to navigate uneven surfaces. Sometimes someone might come in and say, hey, I used to be able to run 5 or 6 kilometers 3 times a week. Now, and after this injury, after a couple of minutes, maybe in the gym, I can't really do the treadmill. And it's very subjective. Different patients, sort of report different symptoms, but essentially the ankle's not quite right. Okay, in addition, about a quarter of patients report persistent ankle pain following an initial injury to the ankle. So these are not that low numbers after all. So in a typical garden variety ankle sprain, it involves an inversion injury. So if you can see in the image on the right, it's a rolling in or turning inwards of the ankle. So this is the most common type of injury that we see. So this photo here is a very typical picture, maybe a couple of hours after an injury, when there's significant pain, swelling, and bruising on the outside of the ankle. How do we treat this injury initially? If you don't remember anything today, just remember RICE: rest, ice, compress, and elevate. So these are the key tenets to treating an acute injury of the ankle. So what do we mean by rest? So essentially, you want to keep off your feet for a little bit, let your ankle rest a little bit, let it recover, let the swelling subside. You want to apply ice packs, maybe perhaps about 20 minutes every 2 hours for the first 3–4 days. An elastic compressive bandage, and this can be found in most pharmacies. That's very helpful to compress around the ankle and reduce the inflammation. Elevation is key, right? So the ankle and the foot is really a peculiar area in the sense that it's the most dependent, it's the lowest part of the body. So it's very hard for swelling to subside. So elevation and the key tenet is to elevate it above the level of the heart. So for the first 5 to 7 days, that's what you want to do to get the swelling and the inflammation down. And as an adjunct, most of us would prescribe a short course of anti-inflammatory medication. Commonly, we would give a course of Arcoxia or Voltaren, and that helps a lot. When should we then be concerned, right? Like I mentioned, 70% of the time, most patients recover pretty well. There are certain red flags. One of them to remember is that persistent inability to bear weight. After an injury or a bad sprain, certainly the first day you'll be hobbling around, but within a couple of days, most patients should be able to walk or at least put weight 50% or more on the affected ankle without much problem. If you find you're still struggling after a couple of days, that is a concern, and you should seek medical attention. Certainly in these cases, an X-ray is warranted. There are certain scenarios where we need to exclude a fracture or other significant ligamentous injuries. What then do we do subsequently? So I talked about RICE therapy. That's typically the first 5 to 7 days after an injury. Following that, there's a period where we do functional rehabilitation. What is that? So it involves early mobilization. You want to do range of motion exercises of the ankle. Use of an ankle brace is helpful during this period, and progressive weight bearing and return to daily activity. So typically in most patients, by 4 to 6 weeks, most are feeling pretty well, and eventually at 2–3 months, you can return to sport. Why is this important? We see a subset of patients who are very conservative. They immobilize their ankle for 6 weeks and the ankle gets very stiff. So if you swing on the other end of the spectrum, that's not good for your ankle as well. Thus the importance of this aspect of recovery. How do we then prevent ankle injuries? So that's a very common question I get. Adequate conditioning, preparation before unaccustomed activity, for example, progressively increasing your mileage when you're training for a marathon. Proper shoe wear is important. I have no investment in any company, but generally I find Asics, New Balance, and Hoka shoe wear to be pretty good for patients with ankle issues. Use of an ankle brace, taping the ankle helps, especially if you have a history of an ankle injury. Strengthening balance exercises under the guidance of a physiotherapist. And lastly, maintaining flexibility. If you see the lady on the bottom right, she's stretching her calf or her gastrocnemius muscle. That's the key muscle to help maintain stability of the ankle, and you want to prevent ankle injuries by doing that regularly before and after exercise. When do we then need a podiatry assessment? So if you look at that photo of one of my patients, you can see that he has a high arch foot. So as opposed to a flat foot, this foot kind of curves outwards a little bit and puts a lot of pressure on the outside of the foot. So about 10-12% of the population have an element of this kind of foot shape. And this actually predisposes to ankle injuries. If you think about it, when your foot curves outward like that, it's a lot more easy to sprain your ankle inwards. So in this scenario, getting a podiatry assessment and orthotics or insoles fitted helps tremendously. Okay, so what problems might one face down the road? So I did talk about this a little bit early on. Chronic ankle instability is an issue. So very commonly, I'll have a patient that comes in, a weekend warrior, plays soccer or basketball, and had multiple injuries in the past. So very often, first injury is fine, second might be okay, and by the time you get your third or fourth injury to the ankle, you start getting what we call instability. So like I mentioned, it's a sensation of the ankle giving way. It might feel weak, and an inability to return to sport or activity. Here you go. So what else might one face? Ankle pain, again, that's very common. You might see it 6 months, a year down the road from an initial bad injury. What could it be due to? One of the problems is impingement. If you look at the x-rays on the lower part of the screen, the red circle denotes where there are bone spurs on the front of the ankle. So this is very common in a footballer, basketballer. Very often you get that. And when the foot jams, or rather when the foot moves upwards or when you're pushing off, there's a lot of pain because of jamming or impingement on the front of the ankle. Cartilage injuries are common as well. If you look at the MRI scan on the right, there is a defect in the cartilage. Very often this occurs on the inside of the ankle as opposed to the outside. So on the outside, the ligament is injured, but the ankle turns inwards and the cartilage jams onto each other. So very commonly, you have a pattern of injury where the ligament's injured and the cartilage injured on the opposite side. And of course, the end stage is that of arthritis. So if you look at the x-rays on the bottom right, that denotes the loss of the joint space of the ankle, and that is end stage arthritis. I've indicated a photo here. If you look at, this is an intraoperative photo where we put a camera into the joint. So a smooth white layer is normal cartilage, and you can see that little crater or the defect in the center of the screen. That is a significant cartilage injury. Okay, so what are the treatment options? Certainly non-operative or non-surgical treatment is the mainstay. We always try that first. So taping and bracing is very important, especially if you have a history of injury. I think my colleague will be talking a bit about that later in one of the later talks. Perennial strengthening is also one of the tenets that help. So the perennial muscles are a group of muscles on the outside of the calf. So by strengthening them, they can compensate somewhat for weak ankle ligaments. Balance and proprioception exercises help as well. So that is a wobble board on the top. So you can see balancing and standing on the wobble board really helps improve your ankle conditions. Activity modification helps, for older patients, moderating your activity. Medication and injections also have a role in patients who have ankle pain. Okay, I'm going to talk a little bit about surgery and where we've moved on from 10, 20 years ago. So traditional ankle surgery is open surgery. So these pictures, not very nice ones, show wound healing problems, scarring, and infection. Certainly in patients who are diabetic and smokers, they're certainly at risk of these complications. So we've moved way beyond that. In recent years, we've moved towards minimally invasive or keyhole surgery for most of our ankle surgery. That results in less pain, less swelling, less scarring, less complications, and a lot quicker recovery. So I'll talk about the various conditions I mentioned before. So if someone has impingement, like in the images above, and there's pain on the front of the ankle, we can do a scope. So we put a camera through a keyhole into the ankle, and we make another hole where our instrument is, and we use that to kind of shave off all the excess bone spurs on the front. So these on the top are arthroscopic images. You can see the instrument on the right. That's a shaver, which is used to remove the extra bone on the front. So that's an image of a patient a couple of weeks after surgery. You can see there's minimal swelling. Perhaps you can see the hint of a scar, a little stab wound on the front of the ankle, but pretty much looks pretty well just a couple of weeks after surgery. Okay, so for cartilage injuries, what do we do? So again, these are arthroscopic photos. We can see that there is a defect in the cartilage on the left, and we use an instrument to drill some holes in it to get the stem cells to come up, and we apply a collagen scaffold. So this is what we do to basically repair cartilage injuries that are present. And the last bit is instability. We talked about instability earlier. So after ankle sprains, a group of patients are unstable and they can't return to sport. So again, this is a fairly new procedure, but we can repair the ligaments again through 3 or 4 keyhole surgeries. You can see these images where we pass the sutures through these small holes and we tighten up the ligaments on the outside of the ankle. Our department has published multiple papers showing good outcomes for these minimally invasive procedures, both for cartilage as well as for ligamentous work. These have been corroborated regionally and internationally with multiple high-level papers. So if you see that lady on the right, she's about 2-3 months after surgery. You can hardly tell she underwent anything over her ankle. And the images on the right show some of my patients a couple of weeks after surgery. Okay, I'll just share this chap who's a patient of mine. He's a striker, one of our local Singapore Premier League soccer clubs. So unfortunately for him, this was a match that was just before the circuit breaker last year. So you can see that he twisted his ankle pretty badly. He had a very significant ligamentous injury. So we went in, we did a keyhole surgery for him a couple of weeks after the injury. So he was fortunate in the sense he had the entire circuit breaker period to recover. About 4.5 months later, this is him. And this is the very first match after circuit breaker. And you can see that he scored a header. If we look at the video again, let's have a look at the replay. You might be able to hear the commentary. So you can see his footwork's pretty good. You can see him getting into the box, getting into position. And there you go. All right. Okay, so he was pretty pleased with his outcome. So even in high-level sportsmen, you know, even more so, you want to do surgery keyhole to provide less trauma to the patient and much quicker recovery. Okay, so how do we prevent such injuries and how do we diagnose them early? So seeking treatment when experiencing pain or instability following an ankle sprain is important. What is the timeline? So typically, I would say most patients at 4 to 6 weeks, if you're able to weight bear, do a course of physiotherapy. Not everyone needs to see a specialist, but typically by about 2-3 months, if you're still struggling, that's the time you want to get in. Get to see one of us and get it assessed properly. You want to institute treatment early to prevent a recurrence of sprains and all the sequelae I talked about, cartilage injuries, ligamentous injuries, impingement. We don't want you to reach that stage before we can do something about it. Certainly, like I mentioned, non-operative management is key, right? It's a big part of treatment, and a lot of patients do get better with non-operative management. Unfortunately, a small group, 30% or so, they still have persistent symptoms even after physiotherapy and various kinds of treatment. But thankfully, we have keyhole or minimally invasive surgery present, and we can get them really back to sport early. Okay, so in summary, what I've covered, what I want you to remember today, what to do in acute sprains, remember RICE, when to seek treatment. I talked a bit about red flags like inability to bear weight. If you have persistent symptoms beyond 6 to 8 weeks following a bad sprain, that's when you really want to seek professional help. We talked a bit about non-operative treatment. My colleague will talk a bit more about that in the last talk. And I mentioned a bit about prevention, and I shared a little bit about minimally invasive surgery. So that's really a pet topic of mine. It's something that I truly believe in. And I think it's made a huge difference to patient care in recent years. I hope you found the talk enjoyable and informative. I've included my email here. I'll be happy to take all questions on the chat of the Q&A. And if you want to email me, I'll be happy to answer your queries as well. Thank you.
All right, thanks, Nicholas. All right, next, I would like to introduce Dr. Fadzil. Dr. Fadzil is a senior staff registrar at the Singapore Sports and Exercise Medicine Center in Changi Hospital, and he is also our visiting sports and exercise medicine physician in SGH and at the Orthopaedic Sports and Joint Center. He himself is a very active sportsman, having been a dragon boater. In addition, he provides medical coverage for many local as well as international sporting events. The last being, he was the Chief Medical Officer for Team Singapore in the Summer Youth Olympic Games in Buenos Aires in 2018. So without further ado, let's get Dr. Fadzil to give his talk on 30 minutes a day keeps the doctor away. Come, Fadzil, to you.
Thank you, Senu. Hello, hi. Good morning, everyone. My name is Fadzil, and today I'm going to speak on something that's more lifestyle related, something that's more practical for everyone. And we're going to talk about physical activity and exercise. So one of the earliest studies on the role of physical activity as preventive medicine, it dates us back to 1961 in London, therefore the photo of the London bus. So we had a group of researchers who were looking at the incidence of heart attacks in more than 50,000 bus conductors and bus drivers who were between the age of 25 to 64, from a period of 1949 to 1958. And what the study showed was that the bus conductors who were more physically active, they had a lower overall rate of heart attacks compared to the more sedentary bus drivers, right? And that's pretty interesting. And what they have also found was the bus conductors had fewer deaths from heart attacks. They compared the direct measurements of the chest, the waist, and the waist circumference, as well as the skin fold thickness of the bus drivers and bus conductors. And what they found was the bus conductors were found to have a lower average waist circumference compared to the drivers. So basically, physical activity not only makes you more lean, but also it helps reduce in terms of your risk from dying from cardiovascular problems. And the years of scientific research have also shown that individuals who maintain a physically active and a fit way of life, they tend to live longer and healthier lives than those who do not. And this association between physical activities and health, it persists in virtually every subgroup of the population, regardless of your age, regardless of your sex, gender, race, or environmental conditions that you're exposed in. So the benefits of exercise, they are overwhelming, as you can see on the screen. And it has been shown that exercise can be used therapeutically for any condition. For example, regular physical activity and exercise not only improves your fitness and your endurance, but also your cardiovascular, your metabolic, your bone, joint, as well as your mental and cognitive health. So it is not only meant for people who are fit, people who wish to keep themselves free of chronic medical problems, but even if you have been diagnosed or if you have an established chronic medical disease and you want to manage your condition better and you want to prevent the onset of complications, exercise is the one for you. And lately, there have been many studies to show that the role of a regular physical activity and exercise in cancer and immunity. All these also apply to special populations, the children, the elderly, people who are pregnant, and of course, those with special needs. In 2004, WHO has listed physical inactivity as the fourth leading cause of death globally. And we already know how physical inactivity predisposes an individual to chronic medical problems, such as high blood pressure, such as diabetes, high lipids, high cholesterol, obesity, and heart disease, which have also been significantly listed as the leading contributors of global deaths. And the scenario has not changed significantly over the years. In 2017, this was published, and again, physical inactivity is also listed as one of the main contributors of global deaths. So the benefits of physical activity and exercise are indeed overwhelming, as you can see. Exercise is indeed the medicine with unlimited refills, unlike your usual pills. And it is able to prevent and manage a multitude of medical conditions ranging from cardiovascular, cancers, orthopedics problems, and even psychological disorders in anyone. The best thing of exercise is it is cheap. It does not require rocket science technology. It is safe, and it is a non-drug intervention which do not have any adverse effects. And it potentially reduces the number of global deaths worldwide contributed by physical inactivity and as well as the medical conditions associated with it. Speaking of death, speaking of mortality, an article in the Straits Times in 2019 reported that Singapore has topped the world in life expectancy. This got many of us delighted because we are most likely going to live longer, right? But if you were to examine the information closely, what you will realize is that the extra years that we're going to spend often spent on coping with age-related health problems. We're going to have more unhealthy years before we die. So the question is, we need to remind ourselves that we have the highest number of people with diabetes in the world, as reported in 2016. And I'm sure we know the complications that come with diabetes. We are the second heaviest people in Southeast Asia. 1 in 3 of us are obese or overweight, and 1 in 10 of us are obese. 25% of us have high blood pressure. That means 1/4 of our Singaporean population have high blood pressure. And apart from cardiovascular disease, 1 in 7 in Singapore have experienced a mental disorder, with depression topping the chart. Many of our parents, our elderly relatives and friends, or even some of us have or are at risk of developing dementia. So the question now that we should be asking ourselves is, are we really living longer, or are we just actually dying longer? A report in 2018 stated that 1.4 billion people worldwide are inactive. 25% of them are adults, 75% of them are adolescents between the age of 11 to 17 years old, and they do not meet the WHO's recommendations of 150 minutes of physical activity in a week. In addition, Southeast Asians, including us, the Singaporeans, we are found to be the least active people in the world. The local national sports participation survey that was conducted in 2017 showed that less than 50% of our citizens are engaged in at least 150 minutes of moderate intensity physical activity in a week. That means more than 50% of Singaporeans are not exercising. Adults, including the elderly, account for the majority of them. But of course, it's never too late to start. If you have never performed any regular physical activity or you have never exercised, then let's start now. Start low and go slow. The aim is to increase your daily physical or daily incidental physical activities and physical activity movements. So break the laze, break the sedentary times, move as regularly as much as possible and make this a habit. Even as you are listening to today's seminar, even as you are listening to my lecture now, I want you to turn the volume up of your computer or of your laptop. Get out of the chair, get off the chair and start walking around. Those of you who are sitting, raise up your arms and stretch. Do circling movements with your shoulders. This is how you try and move as much as possible to break the sedentary times. Try to incorporate more physical activities in your daily essential routines. For example, walk instead of driving to the market. And if you have to drive, park your vehicle slightly further away from the lobby. Alight a bus stop earlier from your point of destination. Take the stairs if you can. Do your own house chores to make your living environment clean and neat. It is surprising. We pay close to $600 to $700 a month for a helper, and we make them do the chores. Indirectly, we are making them more physically active. And that means we are paying our helper to become healthier than us. So, in actual fact, having a helper means that you are likely to have more free time for yourself and for your own physical well-being. So why don't you take the opportunity to start a regular physical activity program if you have a helper, if you have the time? So start walking your dog. If you don't have a dog, walk your neighbor's dog. Take care of your grandchildren and play with them. If you are doing your physical activity, if you're doing your strolls, bring your phone along. Download a step tracking app like the Healthy 365. Aim for 10,000 steps a day. Remember, the journey to 10,000 steps start with just one extra step today. So it doesn't matter if you have only achieved 1,000 steps. Aim for 1,001 steps tomorrow and 1,002 steps the following day. You will get to 10,000 steps eventually. And as you are walking or if you're strolling along the beach or in the park, listen to the music from your Spotify app on the phone. Or use your camera on your phone to take photos of anything that you find beautiful as you stroll along the way. Get your friends, get your family, get your neighbors to join you in your physical activity. And that's how you make this physical activity something that's more fun and less of a chore. Now that you have been increasing your daily step counts as you're moving and inching closer to 10,000 steps a day, the next thing that you need to think of is to plan for a structured and more balanced exercise program using the FITT principles. We're going to talk about the FITT principles in a short while. F stands for frequency, I for intensity, T for time, and the type of exercise. The WHO and the National Physical Activity Guidelines recommend that you should do, apart from 10,000 steps alone, you should be doing aerobic physical activities, and these are basically cardiovascular activities. Cardiovascular activities are activities that make you breathe slightly harder. They make your heart beat a little faster, and they should be of moderate to high intensity. And you should be doing at least 150 minutes of moderate intensity of these activities. In addition, you should also do at least 2 days of strength training activities. And these are workouts. They involve weights, they involve resistance bands, and you should be working out your major muscle groups. For those in the slightly older age group, it is encouraged that you do activities that will train your balancing skills. Things like, for example, your Qigong, your Tai Chi, or even like tandem walking, or even standing on one foot and trying to balance as you are washing the dishes. Try to do these as much as possible and as often as possible, because this will help to improve your balance and therefore prevent falls as you enter into the elderly age group. So now we describe a little bit more on the FITT principle. So the first F, the F refers to the frequency or the number of times in a week that you should be exercising. So it is fine to start off with just one session a week if you have never ever exercised before. But of course, it is recommended that you should aim to achieve or to do 3 to 5 times a week eventually. If you are doing light intensity exercises, then it is advisable for you to do them more regularly, more than 5 times a week, in fact. The I refers to the intensity or the difficulty of your exercise, of your physical activity. And now we measure exercise intensity subjectively by using simply a talk test. So in a talk test, for moderate intensity physical activity, you should be feeling slightly breathless, you should feel your heart beating slightly faster, and you should be breaking out in a light sweat. And while you are performing a moderate intensity exercise, you should be able to talk, but your conversation will be limited to just a couple of short sentences, and you should not be able to sing, or you should not be able to whistle or hum to the tune of your favorite song. Some of us, however, we do have devices that can measure your heart rate. So during moderate intensity physical activity, your heart rate should be between 64 to 76% of your maximum heart rate. And your maximum heart rate, it is simply calculated and derived by subtracting your age from 220. To achieve 150 minutes of physical activity a week, assuming that you are exercising 5 times in a week, you should therefore aim for 30 minutes for each exercise session. Now, some of you might be complaining, right? 30 minutes a session is going to be very long. And it's funny, 30 minutes of continuous exercise feels extremely longer than watching 30 minutes of K-dramas on YouTube or on Netflix. But the good news is you can break that 30 minutes into bouts of at least 10 minutes. For example, you can do 10 minutes of morning brisk walk before breakfast, maybe 10 minutes during lunchtime at work, and another 10 minutes when you come back from work after dinner. And this is how you can actually plan your schedule such that you can have multiple pockets of 10 minutes throughout the day to achieve 30 minutes of an exercise session in the day. For the type of exercises, you can choose anything that you find doing them enjoyable. These may range from household or occupational activities or even leisure time activities or sports. Most importantly, these activities should involve continuous and rhythmic movements of your large muscle groups. So I'm sure some of you will be asking, is exercise actually safe? Well, yes, exercise, especially light intensity exercises, they are generally safe for everyone. However, if you have never exercised before, or if you have any medical condition, engaging in unaccustomed, moderate to high intensity and high volumes of exercise is going to be risky and therefore unsafe, and hence not recommended. You should consult your doctor before embarking in an exercise program involving moderate to high intensity exercises if you are unsure of your health status, you've never exercised, you have a chronic medical problem, be it diabetes, heart disease, hypertension, or even musculoskeletal joint problems, or if you're taking any form of medications in the long term, if you are female and you're pregnant, or if you are practicing certain rituals during special occasions, like for example, fasting during the fasting month. And of course, if you're feeling unwell, then if you have any of these, if you're having any symptoms, please see a doctor before you embark on an exercise program. So the next question is, where can I find a physical, or where can I get a prescription for exercise? So the next time you go to the polyclinic for a checkup, instead of asking for medications or an MC to treat your medical condition, do speak to your doctor. Ask your doctor for an exercise or a physical activity program that is suitable for you to manage your medical condition. Otherwise, you may also refer to this list on the website that I've shown on the screen for the list of doctors who have gone through a rigorous training exercise prescription program that we conduct through Exercises Medicine Singapore. Now, these doctors, they are certified and they are most familiar to prescribe exercise based on your profile and based on your health status. If you do not want to see a doctor, you can see a certified exercise or fitness professional. These are your trainers in the gym. Look out for a trainer who have been certified by Exercises Medicine Singapore, who are certified to work or to prescribe exercise for patients with clinical problems. At the same time, if you do not have a trainer, you can head down to any of the Active Health Labs by Active SG. The list of the labs are found in the list on the website shown on the screen. These are again fitness professionals whom we have trained in Exercises Medicine Singapore. They are trained to work with clinical populations. That means they are trained to work with individuals who have medical problems, and they are the most familiar people to supervise and of course to guide you along if you have never exercised or if you do wish to have some form of hand-holding in your exercise program. So in summary, physical activity can be safe for everyone, for anyone of all ages and of all abilities. Remember, as you choose your type of physical activity, choose one that is appropriate to your fitness level and your health status. Remember, some activities are safer than others. Don't be too gung-ho just because you see your friend lifting 20 kilograms of a bench press. Do not start lifting that just because you want to challenge him or her. Increase your physical activity gradually over time to meet the guidelines and your health goals. Remember, if you have never exercised, if you have never done any physical activity program before, start slow. Choose to do your exercises in safe environments, especially in a COVID situation like now. Follow your rules and the policies in the gym. Protect yourself by using appropriate gear and sports aids. Put on a mask if you are just doing light intensity exercises in a crowd. Consult your healthcare provider or your doctor if you are in doubt, especially if you have a chronic medical problem or condition, or if you are experiencing any symptoms. So with that, I think I'll end here. I'll open the floor to questions later. Back to you, Senu.
Right, thank you very much, Dr. Fadzil, for the very engaging session on teaching us how to do the appropriate way to start off an exercise regimen. Okay, next I would like to introduce Miss Josephine Lim. She's a physiotherapist with SGH. She has a master's in clinical physiotherapy. She's a sports major, in fact, from Australia. And she has been working extensively in the area of musculoskeletal and sports physiotherapists with a wide clinical experience across various musculoskeletal conditions. And she's also actively involved in teaching within the SGH Musculoskeletal Physiotherapy Residency Program. So I will pass now over to you, Josephine, to tell us a little bit more about sports physiotherapy. Thank you.
Okay, good morning, everyone. Thank you, Prof, for the introduction, and thank you, everyone, for tuning in. My name is Josephine, and I'm a physiotherapist from Singapore General Hospital, and it's also one of the therapists leading the sports physio team in SGH. So here's an outline of what we'll cover today. Firstly, I'll briefly go through the role of physiotherapy in sports, and then followed by an overview of how we rehab our athletes and general population back to activities after sports, and sports after an injury or surgery. And then lastly, giving you some tips on how you can do what you can do to minimize the risk of injury or re-injury when exercising. So have you ever wondered what is the role of physiotherapists in sports, or have you seen a sports physiotherapist before? We are involved in the prevention and management of injuries that resulted from sports and exercise participation. This is actually regardless of your age and your level of ability. And we also provide evidence-based advice on safe participation in sports and exercises. And together with the doctors and other healthcare professionals, we work to promote active lifestyle to help our population improve and maintain their quality of life, as well as restore optimal function. We also contribute to the enhancements of sports performance together with coaches and other healthcare and exercise professionals. So sports physios work in many different settings. Many of us work with active recreational individuals in hospital or clinical settings. Some will be involved in the social and club level of sports and attend the athlete training sessions and cover their games to manage any acute injuries during the game. There are also sports physios who work with the elite athletes in competitive and professional sports. That's where they will work and travel together with the athletes and the team, and working together with the medical professionals, the coaches, the strength and conditioning staffs to assist the team and athlete to win the competition. So here in SGH, we have our clinical area with gym facilities and running track to assess and manage our athletes and general population who would like to return to sports or adopt an active lifestyle. So what happened after an injury or surgery? So how can you return back to sports or exercises if you have any pain or injury or surgery? For many of you who have attended last week's session, our physiotherapist Sani has probably given you some idea of what our rehab looks like after injury or surgery. So here, I'll be giving you an overview of the process that you might be going through in sports rehabilitation. So after your injury or surgery, the aim of the physiotherapy in sports rehab is to restore your function and performance level to help you to return to your sports participation in a safe and timely manner, as well as to provide education and ways on how you can prevent the risk of re-injury when you return back to your activities. So we know that injuries in sports happen quite commonly. The recovery time frame can actually depend on many factors, such as the severity of injury. For some injuries, the healing can take a couple of days or couple of weeks, but for others, the recovery time frames can be protracted. But regardless of the overall duration, your rehab will be progressive to gradually return you back to your previous activity or goal. So let's say, for example, you have a knee injury or knee surgery done, or a hip injury or hip surgery done. The first thing you have to do is to adequately protect and offload the affected areas, such as using a walking aid to walk. This is not only to avoid injury from getting worse, but to also promote an internal environment to support healing. Also, at this stage, the affected area are often painful, so offloading and adequate pain management are necessary to allow the healing process to take place. So following the initial phase of management, this is when we'll start gentle exercises to improve the resilience of repair. In addition to rehabilitating the specific area of injury, it is also important not to lose sight of all other conditions, such as your cardiovascular fitness and strength of other parts of your body. And once your injury and healing has kind of settled, this is the stage when usually your pain will be gone, your strength is good, your range of motion has probably restored. And many people at this stage, they will feel that they are ready to go back to their games and ready back to their to play. But you still have to address deficits that are required to return to sports, such as your cardiovascular and muscular endurance, your power, your agility, your balance at this stage. So once you are both physically and mentally prepared, if you're able to clear all the objective targets and milestones with your physios and the doctors, this is the phase where you can gradually ease back into your sports. And of course, when returning back to your sports, the final stage is prevention of re-injury. This is because you don't want to get re-injured again after going through this long process of recovery and rehab. So other than the severity of your injury, there are some other common factors that can affect your recovery and rehab outcomes, regardless of whether you go through conservative management or post-surgery. Firstly will be the response to injury. So things like your thoughts, your belief, your emotions towards the injury can affect your recovery. So for example, you had a fall and you sprain your ankle. And because of that, you have pain at the ankle and you don't dare to move because you believe and you fear that the ankle will be damaged if you move more. Even though the fall may have probably happened many months ago and the healing has probably settled. Unfortunately, this is one of the very common unhelpful belief and thoughts that we as a physio, we see a lot in our patients, and that will actually prolong the recovery time. Another thing is lifestyle. There's a good evidence on how lifestyle factors may affect your pain experience. So lifestyle factors such as lack of sleep, poor nutrition or diet, smoking habits, lack of physical activity, or being sedentary can negatively affect and slow down your recovery as well. Poor general health and comorbidities such as diabetes can also slow down your body's healing and recovery processes. So having a healthy living and introduce habits that can improve your health and manage your stress as early as possible, like what Dr. Fadzil said, are really important to improve your recovery process. So now you have completed your rehab and you have already started easing back into your sports. The next thing you have to ensure is to prevent injury from happening again. For those who are not having any pain or any injury right now, prevention is always better than cure. It is definitely easier to stop something from happening in the first place rather than to repair the damage that has happened. So what can you do to reduce the risk of injury or re-injury? So prevention of re-injury does not only look at the specific area that has injured before. For safe return to play, we have to take into considerations many components such as the way you run, your psychological readiness to return to play, the load that you can handle, your strength and fitness, etc. And it is important to note that excessive loading or rapid increase to your physical activity level, which your body or joints cannot cope, leads to pain and injury even before you reach your goal. So therefore, once you've gotten all the clearance from your doctors and physios to return back to your activities, you will need to start slow and light, start slow and steady. Gradually progress each day to ease yourself back into your top form. This also applies to those who have not gone back to sports or exercises for months because of certain reasons or COVID regulations. So some last advices here. Do not assume that you are as fit as before if you have not been exercising. Start slow and steady. Try not to rapidly increase your physical activity beyond what your body or joints can tolerate. And before you exercise or play sports, take some time to warm up to reduce the risk of injury or risk of muscle strain. Example of simple warm-up can be low-intensity exercises such as slow jog or stationary cycling if you are in the gym. Also, ensure your body have proper rest and nutrition to recover after an activity or exercises. So for example, let's say you have just finished working out and you need to actually rest for at least 1 or 2 days before another workout sessions that target the same muscle group, especially if you're just starting out. This is because muscle building process requires energy and fuel in the form of sufficient sleep and proper nutrition. And also when you're playing or doing your activities or sports, take regular short breaks in between your activity to make sure that you're not pushing through too much to cause an injury. And lastly, always keep your expectations in check. You may be very driven to head back into your sports or competition, but the reality is that your body may not be able to handle that load. So give yourself some time to pace yourself and ease back into your sports. And also understand that it is natural that your body will need some time to build back its stamina and strength. So here I've come to my end of my talk. If you have any questions, feel free to type into the Q&A box and we'll try to answer them. I hope this will be an informative session for you. Thank you very much for listening. I'll hand over back to Prof. Fo.
Right, thank you, Josephine, for the very enlightening talk on sports physiotherapy. You've covered all the bases, about return to sports and what physiotherapy is all about. And so now we've come to the most exciting part of the forum, which is the Q&A. I'm sure a lot of you have burning questions to ask, and we've tried to type in our responses as much as we can within the Q&A, but obviously, we can't answer everybody's concerns or questions. So we'd like to do some of these live. Maybe let's have everyone turn on their videos so that we have all our panelists on board. So we can start off, perhaps we can start off with the ankle section first. Nicholas, do you have any questions that you would like to answer live? And all right. Nicholas, you're muted. You want to unmute yourself first?
Can you hear me now?
Yes.
Yeah, maybe I'll just summarize some of the questions that I've answered already. Is that okay?
Yeah, sure. That's fine.
Okay, so I think this one of our audience, CL, was asking about ankle ligament repair and what is the most advanced, what we do nowadays. So just to summarize, I think I mentioned in my talk, a lot of our surgery now is minimally invasive or keyhole. So that can be, ligaments can be reconstructed in that way. And we actually use anchors or sutures to reconstruct the ligaments following an injury. And that's typically what we do. The recovery is pretty quick. Most patients are on their feet 3 weeks after surgery. And after a course of rehabilitation, we aim to get them back to sport by about 3 months. CL also asked about how we can expedite recovery and from this surgery. He asked about PRP. It is an adjunct. Sometimes we use that to help in ligament and tendon healing. But I think really the key post-operatively is the rehabilitation. So I think getting into a program under the guidance of a sports physician or sports physiotherapist is really important. I find that's really key. If a patient doesn't invest that amount of time to recovery, as much as I do the best surgery in the world, he's not going to get the best outcome. So it's always two parts that make a good outcome. Okay, I hope that answers that question by CL. Let's see. Maybe I'll just summarize one more, then we can move on to the next person. Okay, someone asked about, so this is a very common question I get about bone spurs. I think it's not specifically about ankle injuries per se, but someone asked about, can excess calcium in food and supplements cause bone spurs? So I don't think there's any evidence for that. We haven't had any strong evidence. So there's no need to worry. If you have osteoporosis, you should continue your calcium supplements. Seng Yu, you want to take some of the questions?
Yeah, I'll answer some of the hip questions that were put up. All right, so I think there was always a lot of concern about, when is the time to come and seek a medical treatment? When should we do an MRI? Okay, so I think the most straightforward answer to this is, okay, really you have to look at your symptoms and how is it affecting you. Okay, if you have pain that is constant, for example, pain all the time, pain at rest, if there are systemic symptoms, for example, you're having fever, loss of appetite, loss of weight, these are red flags for something dangerous, okay? And it's better for you to come in and let us do an evaluation to rule out dangerous conditions like infections or tumor, all right? But barring that, if it's a sports-related injury or if it's an injury that's affecting your lifestyle and the pain is significant enough to make a substantial change in your lifestyle, I think it's a good time for you to come in to let us evaluate. Perhaps we can do something and to make the condition better or to prevent it from progressing to the point of osteoarthritis, when you need some form of more aggressive or invasive treatment. Right. I also had a few questions on labral tests, whether it's possible to prevent it. All right. So labral tests come in many kinds. All right. So if there's an underlying bony deformity, unfortunately, it's already there. So that's very unlikely for you to be able to change that bony deformity without some kind of surgical intervention. But if it's due to a trauma, for example, you had twisted your hip, certainly a period of rest, anti-inflammatory medication is useful in helping the labral test scar down. And I've had a lot of patients who actually, the pain comes down to a point where they can go back to full active lifestyle. In such cases, obviously, conservative treatment is successful and we don't need any further intervention from that. But it's the ones that have underlying bony deformities that we probably should treat, either in the form of a femoral acetabulum impingement or hip dysplasia. All right. Then with regards to the exercises for the hip, how do we maintain, how do we do the exercises to prevent hip injuries? So a few things that can be done. Okay, so we in exercising, we always, or rather this is rehabilitation for hip injuries. We always look at two main areas. One is stretching. Okay, stretching is essentially to move the hip throughout its range of motion so that to maintain the suppleness of the joint. And this one you can do on a daily basis. All right, and it's probably better if you are not very sure about this, to see one of our physiotherapists who will guide you through the process. And then the second area of exercise goes towards strengthening of the individual muscles. And there are muscles in the front of the thigh, the side of the thigh, the buttocks. And we want all these muscles to be strong so that, they provide some dynamic stability to the hip joint, as well as to balance out the hip during your movements, especially if you're doing very aggressive or vigorous sports. And so usually this exercise program needs to be done at least 2 to 3 times a week. And how we should do these, it's probably better for you to come in and let us do an assessment to make sure that, first of all, we rule out all the underlying serious conditions or have treated them, and then we recommend what is the best sort of physiotherapy regimen for you. And it usually requires some time to work. It's not an immediate treatment, and you have to persist with it for a period of at least 6 weeks before we start to see an effect. Yeah. Next, maybe we pass on to Dr. Padzil. Are there any questions on your side that you think would be useful to be answered live?
Yeah, so a lot of them are asking about how do you do certain exercises for certain conditions and prevent certain injuries. So I think there are a multitude of exercises that you can do. As what Fenu has spoken, one of the very important ways of which you can prevent yourself from getting sports injuries or overuse injuries is to make sure that you do a warm-up. Warm-ups are very, very important. Basically, it is meant to warm the muscle up because once you do any form of activity involving a cold muscle, you are therefore predisposing the muscles to injury and the joints and the ligaments as well. higher or more intense physical activity that you're going to be doing as part of your exercise. So therefore, to prevent an injury that's associated with your type of activity that you are going to do, it is important for you to do a warm-up that mimics the activity that you are going to do. For example, if you are going to run or if you're going to go for a jog, when you jog, you're going to use your lower limbs, you're going to use your hips to swing. So therefore, it is important as part of your warm-up, you do certain activities that will warm up those muscles of your lower limbs and your hips. So things like, for example, doing simple jumping jacks, or even like simple stretches to stretch the gluteals, or your backside muscles, or your calves, or your hamstrings and your thighs. So these are certain warm-up exercises which mimic or the activity that you can do, and they are targeted at the muscles which will be used during these activities. Fadlu, maybe you would like to add on these warm-ups as well.
For warm-ups, right? So let's say if you would like to do your legs workout in the gym, for example, we usually start with a very, very low intensity kind of exercises. So let's say today you want to start strengthening the calf. We will only start with probably just like body weights, kind of low intensity warm up just by doing some calf raises. That will also be sufficient to help you to warm up the muscles as well. Does that answer the questions, Dr. Fatso?
Yes, definitely. Yeah. So the other question is, a lot of people are asking about, whether the link to those websites which I've shared in my talk will be shared. I suppose the organizer will be sharing the slides. I guess I will let the organizer share the slides with all of you. One more thing is, some of you are asking, like, if you have family, if you're a family with young children, should you be exercising together? The answer is definitely yes. In fact, the physical activity guidelines for young children is such that you would want them to move as much as possible daily. And it is even more than 150 minutes a week. So I think it is a good practice. It's a good habit that you want to nurture as a family, it's a family activity. It bonds you together. It gets everyone going, gets everyone moving. And of course, it inculcates the right values of staying physically active in the family.
Great. All right. Maybe I'm just looking through some of the other questions. Okay, we have a question from Janet Leong, who's asking about why hip preservation has to be done before osteoarthritis set in, and whether it's the same as knee preservation. So like any joint preservation for both hip and knee, so essentially the whole idea of joint preservation is we want to maintain the normal status of the joint for as long as possible. So you want the cartilage to be in its best condition. For us to treat the labrum or the meniscus in the knee, for example, it's not as difficult as treating the cartilage, because cartilage growth is extremely slow and sometimes unpredictable. So really what we want to do in joint preservation is prevent the cartilage from wearing out, because once the cartilage wears out, for us to restore, especially a large area of cartilage loss, is very difficult. And so what we are essentially doing, right, is we are trying to alter the forces around the joint, make sure that within the joint itself, all the structures like the labrum or the meniscus in the knee joint, for example, are in their ideal state, so that the knee or hip will not progress to osteoarthritis. Because once you reach there, and especially if the osteoarthritis is severe, the only other way is joint replacement. That is probably going to be the most reliable treatment then. And so it's always important for us to treat this early before the osteoarthritis sets in. Any other questions on your side, Nicholas? You want to answer any of them live?
Maybe I just address. I had a couple of questions on how do you prevent injury to the ankle, and how do you strengthen the ankle? I'll give my take, then perhaps Fadzil and Josephine can chip in. I think that's really their area as well. I mean, it's something I truly believe in, and I actually do spend a lot of time with my patients explaining what to do. Right. So in terms of if you had a single injury or you had history of ankle sprains, a lot of times, I think to summarize, I think it's stretching and strengthening. Okay, I think the calf muscle is really important. Okay, a lot of times we find that a tight calf muscle puts a lot of stress on the foot and ankle area. So before you start your strengthening, you stretch first. So stretch the calf muscle out. What can you do in terms of strengthening? Okay, a lot of people say, hey, the ankle is such a small joint. Is there any muscle around there that I can strengthen? I can do some kind of exercise. So the perennial muscles are quite important. I did show a slide with a TheraBand, so that you can easily buy that in any Decathlon or some shop. So resistance exercise of the perennials, I find that helps a lot. So use the TheraBand to sort of stimulate some resistance, and you do a resistance strengthening of the perennial tendons, which is essentially turning the foot outwards. So that's the biggest muscle that's near the ankle joint that you can train to compensate for some weakness around the ankle. The second thing is balance. So balance and proprioception activation is very important. I find the wobble board is very helpful. Perhaps in older patients, a bit difficult, but it can be trained. But in the gym, the wobble board is like this semicircular device and with a platform on top. So if you can master that, you've really got your balance there. So I find that very helpful as well. Maybe Fazil and Josephine, any tips for patients with ankle injuries?
Yeah. Okay, Josephine, please go ahead.
Okay. I think if you don't have a wobble board at home, another way you can do is to use a cushion or pillow to step on it. But make sure that you set your environment safe when you do that. You can stand on single leg on the cushion or the pillow, and that will actually help to work in the strength of your intrinsic foot muscles as well, which is also important.
Yes, I was just about to add that, if let's say you are having difficulty even to stand on a pillow or a pile of clothes at home on one foot, I think the first thing that you need to do is to be able to stand on hard ground on one foot for at least 30 seconds without falling to one side. I think this is one of the ways in which you can actually do things progressively for your balance exercises. So simply what I usually tell my patients is, if you are washing the dishes, stand on one foot, try and wash dishes while standing up. You just stand on one foot and then alternate with the other one as well. That will help to train your balancing skills, and at the same time, trying to incorporate all these rehabilitation exercises as part and parcel of your daily activities. So it doesn't feel like you're spending extra time to do it. So it becomes part of your schedule, part of your routines. Apart from that, apart from balance, I think it is also important for you to understand that injuries don't just happen because of muscles which are surrounding one joint. Typically, if you look at your lower limb has many joints. So you have your ankle, your knees, your hips. So basically, it is a chain, right? So if one joint is defective, it doesn't mean that you're just focusing on that joint, everything's going to be solved. And this is where the physios, really, I really value the physiotherapists, the rehabilitation exercises a lot, because they're not just focusing on the muscles of that joint alone, they are focusing on the muscles of the whole lower limb, because we know that they're all interdependent. So yes, you may start off by doing some exercises to focus on these muscles which are localized on the joint, but ultimately I think to return back to function, to make sure that you're able to apply all these things, it is important for you to strengthen the lower limb, your posture, your gait, the way you move as a whole.
Thanks, Fazil and Josephine. I think it's very insightful. I like your advice on incorporating it into your daily life. So I think that's very, very helpful. We're all very busy, right? So, to do that really helps. Singyu, anything?
Yeah, I think actually on that note, I was looking through the questions, and there are a lot of people who are interested actually in learning more about the exercises for the various joints, and in fact they are asking us if there's a possibility for us to hold some kind of session dedicated to doing that. So certainly I think we can look at that. I mean, with that kind of interest, we should definitely look at working with Fazil and Josephine to maybe hold a separate session where we can just dedicate to doing some of these exercise programs, as well as specific maybe hip, knee, ankle rehabilitation exercises. I think that would be quite welcome. Yeah. Okay, so I was looking through the question list, and also there were some questions on hip and knee replacement. There were some people who were a bit concerned about whether it's going to wear out, and what is it like. Obviously it's not in this forum because this is more of a sports forum, but just to put everyone at ease. Okay, so essentially we in SGH we also do a high volume of hip and knee replacements, and certainly I think what you can expect is quite different from maybe what you might have heard from your neighbors or friends who had done hip and knee replacement many years ago. Usually, post hip and knee replacement, barring any major complication, usually we get our patients to walk the next day, albeit with a walking aid, and our physiotherapists go in the next day, and they're very hands-on. We start to do range of motion motion exercises. We start to, help them to walk with their walking aid, to correct their gait posture. And, usually our patients stay about maybe 2 to 3 days. And some, even as fast as within a day, they can be discharged. So it all depends, of course, on what is the underlying state of the hip or knee, what is the state of arthritis, how severe it is, and also, what's the underlying muscle condition, that means how bad have the muscles wasted, because of a period of disuse. So if the muscle condition is good, usually the patients recover very fast. And, going back to your natural lifestyle, it can be as fast as 6 weeks, or it may take months, because there's a lot of variability in that, depending on what was the original state of the hip or knee. All right, but certainly the aim is to get you back to your normal lifestyle, and hip and knee replacements are known to reduce pain by as high as 80 to 90% of the time. Right, so I don't think that is necessarily a bad thing to do. The only issue, of course, is they do come with complications because it's a much more invasive surgery. So obviously we have issues of complications such as infections or dislocation, for example, in the hip joint, loosening. They're not so suitable for young patients. The main reason is because young patients tend to be much more active, and they go through much more movement cycles. And certainly there's fair amount of data that suggests that in young patients, these replacements tend to wear out a little bit earlier than the 10 to 20 years that we usually counsel our patients for. But certainly, if you've already reached an end stage osteoarthritis, sometimes there's no choice. And then so hip and knee replacement is definitely a good option to be considered. We also had, I think I saw another question on hip dysplasia and, how does it occur, and whether there's any way to prevent it. I think hip dysplasia is largely, to a certain extent, a congenital issue. Yeah, it's a developmental issue with the hip. A lot of it is inborn. So you're born with a shallow acetabulum, and then if your activity, is quite high, that in turn increases the wear rate. So the exercises we generally recommend for hip dysplasia very much goes towards stabilizing the hip joint, and that is, to strengthen the muscles around the hip, largely in the front of the hip, the side of the hip, as well as around the buttocks. And this, the physiotherapists are usually, we usually work closely with them to design an exercise program. Fenru, you want to emphasize a little bit on hip rehab? Do you have any tips on what are the things that you do for hip rehab? Yeah.
So for hip rehabilitation, it really depends on what type of injury you have. But usually we'll do things like improving the range of motion of the hip, doing some stretching exercises for the hip, as well as strengthening the muscles around the hip and the muscles that are essential for your daily functions. And it also depends on your goal as well. So if your goal is definitely to play sports, right, we don't just look at strength anymore. We will have to look at many other components like the biomechanics, the way you walk, the way you run, the way you jump, and the way you land, and the way you move, or your agilities and skills as well. Yeah, so there's a lot of things that we'll have to look into it when you do your hip rehabilitation.
Great. Great, thanks. Yeah, I also saw some questions on adjunctive treatment like PRP. There's a lot of questions asking us about PRP. Okay, so maybe I'll answer for the hip side. All right, the data actually is not strong. There are some studies that suggest PRP does help, and it's more towards the hip osteoarthritis part. The treatment effect is low, but certainly there are some patients who do report better results. With regards to whether PRP helps labral tears, that evidence is much more mixed. Okay, so generally we don't recommend PRP alone for labral tear treatment. How about for the ankle? Is there a role for PRP in the ankle, Nick, you think?
Yeah, so I echo what you say. I think the evidence in general for PRP is not terribly strong, but it can be used as an adjunct. Some people give PRP into the joints. I think the evidence for joints is less strong. There's a bit more evidence for soft tissue. So things like ligamentous injuries, perhaps even enthesiopathies like plantar fasciitis, Achilles insertional pain. But again, it's not very strong. I think it's an adjunctive treatment. Sometimes if patients have exhausted all other options, we can give them a try of PRP. It's not very invasive, but it's probably just the cost, whether the cost-benefit ratio makes any sense. But definitely we should keep an eye on the evidence. This evidence evolves, and it's hard to say. Sometimes in a few years' time, you might find that certain conditions it might show good results. But in the foot and ankle in particular, I think limited role. I do offer it once in a while, but certainly not my first line treatment option.
Yeah, similarly, actually for the hip as well. Yeah, other than for the joint itself, we also do consider PRP injections in the hip abductor tendon tears, especially if they are partial tears. Certainly, we don't do them for like full thickness tears, but for partial tears, PRP has been shown to have some effect. But all of these need to be targeted, which means you need some kind of image guidance, either through ultrasound, and it's usually through ultrasound. Yeah. Yeah, Dr. Fadzil also does quite a fair amount of PRP in his practice, right? Do you have any?
Yeah, so I think apart from, I think like most of you have answered my points on PRP, but I think I would just like to highlight another modality which is often, in fact, being used now currently, which is ESWT or shockwave therapy. And I think I've got a lot of patients coming to my clinic asking for shockwave therapy for certain conditions. Yeah. Now, shockwave therapy, it is a non-invasive mode of treatment where it helps in terms of reducing pain. And at the same time, in the long term, it helps in terms of the healing of the soft tissues. So usually and typically in our clinics, in SGH, in fact, in CGH or in Sing Health, for example, we tend to use ESWT for soft tissue overuse injuries, like, for example, your plantar fasciitis, your Achilles tendon swellings, or even your rotator cuff, your shoulders, rotator cuff calcified tendon swellings as well. So they are non-invasive, they are effective in terms of pain relief, but they are not first-line treatments. Because ultimately, if you look at it, these injuries, there are predisposing factors, there are contributors for them. So if you were to do an ESWT without even addressing the contributing factors, yes, it does help you in terms of relieving the pain, but that's just going to be temporary. Once you start back your activities and you start going back to the poor posture that you are working in, chances are you're going to develop the symptoms again and the condition is going to recur. So my take for this is, yes, PRP, shockwave, they are important modalities, but they are best to complement the physiotherapy and the rehabilitation offered by the physiotherapists.
Yeah, thank you, Dr. Fadzil. Yeah, that's a very comprehensive answer. Yeah, let's look at it. I think there were some questions, also about, how do we, get into touch with the specialist, either a sports, orthopedic surgeon or sports physicians. And I think the PLS side, Samuel and Hyman will probably be sending you all the links as well as the QR codes, for you to make an appointment or give your patient details. And that probably will help you make your appointments to see us. Any other questions from any of the panelists that you would like to answer live? I see some questions on supplements. I think there were quite a number of questions regarding use of glucosamine, NC2, for example, right? So I think for us, these are at the end of the day supplements. So there has been some data, especially in the 80s and 90s, for glucosamine use, and has been shown to have some clinical benefits. But if we look at the randomized control trials that come out of 2000, a lot of them show not much difference. Okay, so we're not saying that they have no use, but you have to take them with a pinch of salt. So at the end of the day, they're supplements. The treatment effect for supplements are probably going to be lower than if we do an intervention, for example, like anti-inflammatory medication, for example. But certainly, what I usually tell my patients is, if you take it and you find that it benefits you, I think there's no harm taking it. But if, let's say, after you've been taking it for 3-6 months or even a year, and you see absolutely no benefit, the pain is continuing, it probably means that you're not responding to the supplement, and maybe you should, discontinue it. Yeah. Any opinions on this for Nicholas or Fadzil on the use of supplements, either glucosamine, NC2?
Yeah, so I think I did reply on a couple on the chat as well. So Senu is absolutely right. I mean, there's no really strong evidence for supplements, but I do have patients that actually feel better. So I have patients who come in with knee pain, you know, ankle pain, and they take glucosamine or Ginflex, and they do tell me, hey, you know, I actually stopped it, and you know, the pain came back a little bit. I believe there is some anti-inflammatory properties in some of these supplements, and to me, the advantage is that you don't have the side effect profile of traditional painkillers, right? So if you're on NSAIDs or, you know, Arcoxia in the long term, that might affect your kidney or your gastric lining, these supplements tend to have minimal side effects. So in that sense, no harm. But the same thing, I would say, you know, if you take the supplements and you don't feel any different, I would probably say, you know, you can stop lah. There's probably not much effect. Common question is that, hey, you know, if I take the supplement, does it grow my cartilage back? So again, the answer is no. You know, there's absolutely no evidence for that. But I would say the advantage of taking it is that if that you do have a treatment effect over a course of period of time, then I think there's no harm taking it. Yeah. Fadzil, what do you think?
Yeah, so I get the same questions as well from my patients, and I tell them that supplements are not magic pills. You know, they don't solve the problem. They basically help to support your health. They are like your multivitamins. You know, so ultimately, I think what's important is if you're talking about musculoskeletal joint health, nothing beats physical activity. Nothing beats getting it being diagnosed first. That's important. Yep. And if you are taking any of these supplements, be it those that you buy off the shelf, those that you get from the Sensei, please do inform your physicians, your doctors who are seeing you, so at least we can advise you further.
Yep, great. I think now it's 11:50. We've tried to answer as many questions as we can, and I'm sure that there will also be, you know, a lot of you will still have burning questions. So the Samuel and his team will leave you with an email for correspondence. So if there are any more questions that need to be answered or you have burning questions, just feel free to send it to them, and then you will direct it to us, and then we will try to answer them as best as we can. And in the meantime, if you see us, just let us know, you know, how we can help you. And certainly, we are looking forward to organizing more public forums, you know, to improve awareness about joint conditions as well as exercise and rehabilitation. Thank you very much.
Okay, thank you.
All right, thanks.
Thank you, everyone.
Thank
Samuel,
you, everyone.
do you have anything for them, or Yep, Samuel, maybe we'll pass over to you, and you can leave our, you know, the links and QR code for them to contact us if necessary.
Yes, Prab. Yes, we will share the link soon. Yes.
All right. Okay then. All right. Thanks, everybody. Okay then. Keep in touch. Stay safe during this COVID period, and we look forward to seeing you if you happen to come to SGH. All right. Goodbye.
Bye. Have a good weekend.
Okay.